First of all, how many people know what an interventional radiologist is? Not that many, actually. I think we need some advertisements on Facebook. I'll give you a quick rundown. Basically, we're radiologists. We do a residency in radiology and then extra training to learn how to do procedures using imaging guidance. And so all the procedures that we do are minimally invasive and done through tiny incisions, and we use things like CT scans and ultrasound machines and fluoroscopy to do these procedures. Fluoroscopy is basically video x-ray. And so today I'm going to talk about 4 procedures that we do for neuroendocrine tumor METs. Ablation, percutaneous ablation, which is a procedure where we use CT and ultrasound. And then transarterial procedures, bland embolization, chemoembolization, and radioembolization. And those are all done through a tiny incision in the wrist or in the groin. We put a small catheter into the artery and snake the catheter through the arterial system into the liver arteries and treat tumors directly through the arteries that feed them. So first I'm going to talk about ablation. There are many different types of ablation modalities. I use a lot of microwave. Microwave involves basically heating the tumor to really high temperatures and burning the tumor and a margin of normal liver around the tumor, basically incinerating that region. So this is the microwave ablation probe here. And what we do is basically take this probe and use ultrasound and CT to go through the abdominal wall and into the metastasis, and then we burn. So this is a procedure that I did a while back. This is the patient here that's sterilely draped, and we have 3 ablation probes sticking through the abdominal wall into the liver, and that's my one slice of the CT scan that's helping me guide those probes. And this is some 3D fusion software that we have, which basically we define our target and we can see where our probes are in relation to our target and really make sure that we're going to get an adequate burn and a nice margin, and it's a helpful technology. And so this is actually that same patient. You can see the metastasis, which is actually was quite large. It's on the larger end for ablations, close to 5 centimeters, and up at the dome of the liver, which can be hard to get to. And 3 months later, this is the ablation defect. It's more homogeneous. There's no tumor left there. The patient did really well. Symptoms pretty much gone. And this procedure is very well tolerated. Patients leave the same day, and they might be tired and a little sore for the next day or a few days, but you can pretty much get up and walk out of the hospital same day. So indications for ablation, these are all the procedures that we do are basically for non-surgical candidates. And primarily we're doing these procedures on patients who are either symptomatic or they have tumor growth despite standard of care. For ablation in particular, what we're looking for is tumors that are less than 5 centimeters. And it's really a procedure also that we do for relatively few number of tumors. If there's a lot of tumors, say more than 3, maybe we'd opt for a transarterial procedure. And outcomes are, fairly good. So symptom improvement happens in more than 90% of the patients that we treat with ablation, it lasts for an extended period of time. Local recurrence rates are low, and 5-year survival is high. Complications are actually quite low for this procedure as well. Infection, bleeding, injury to the liver and organs that are around the liver can happen, but are rare. Mortality is also very, very rare with this procedure. And I think the mortality with all of these procedures that we do, there's always a couple cases of carcinoid crisis. So when we treat neuroendocrine tumor patients, typically we have patients on octreotide drip to prevent carcinoid crisis. So moving on to transarterial embolization procedures, which includes bland embolization, chemoembolization, and radioembolization. So all of the transarterial procedures basically are based upon this dual blood supply that the liver has. There's the hepatic artery and the portal vein. Both of those supply blood to the liver. The portal vein actually supplies the majority of the blood to the liver. However, tumors almost entirely rely on blood supply and nutrients from the hepatic artery. So that sets up this nice situation and dynamic where we can actually treat tumors directly through the hepatic artery and do that pretty effectively. So this is a picture, this is a hepatic artery. Basically, this is a tumor, and this is our catheter, and we're injecting our particles, our embolic material, into these arteries and into that tumor. So we'll start with bland embolization first. These are just basically microspheres. We say bland because there's no chemo or radiation attached to them. And the idea behind this is that these particles will just simply block the blood flow and starve the tumor of oxygen and nutrients and cause cell death. Now, chemoembolization, there are two types of chemoembolization. There's a type of chemoembolization where we use those microspheres and load them with chemo. We actually don't really like using that anymore because there's a higher incidence of infection and biliary injury. So we pretty much rely on conventional TACE. It's called Transarterial Chemoembolization is what TACE stands for. And that's basically oil mixed with chemotherapy, usually doxorubicin. And we inject that mixture into the arteries feeding the tumor. The tumor's soaked in chemotherapy. The chemo usually it doesn't go into the systemic system, and you don't get those systemic effects as you would with injecting chemo into the vein. So you get kind of a double hit. You bathe the tumor in chemo, and you also block the blood vessel and starve it of nutrients. Indications are for bland embolization or chemoembolization. Again, these are all non-surgical candidates. You need to have tumor growth. There needs to be a reason why we're treating you. You've got tumor growth or you're symptomatic. And usually we're treating people with less than 75% of tumor replacement of the liver. And you also need to have good liver function because there's always some degree of liver injury with these procedures, although usually small. And this is just a picture of us getting access into the common femoral artery in order to do this procedure. This is quite a small needle. It's a very small incision. And so this is a CT scan over here. These can be hard to look at if you're not used to looking at them. But the bright spots here are metastases, and the darker area is normal liver. So there's multifocal metastases in the liver. We call it hypervascular because they're sucking up contrast, which we've put into the bloodstream in order to identify these tumors. And so we've decided to do a chemoembolization for this patient, and this is the angiogram. So this is the artery here, and this is the tumor, which is, on the angiogram, the contrast is dark, it's black. And the tumors suck up blood flow preferentially compared to normal liver, so the tumors turn black. So that's tumor there, and you can kind of see that there are some arteries that seem to be feeding that tumor. And when we're doing a chemoembolization, we'll look for those specific arteries and we'll selectively go into them and block them and spare the other arteries that are feeding the normal liver. So as far as outcomes for bland and chemoembolization, they're pretty good, and they're also really similar, with a trend towards chemoembolization maybe being a little bit better, but that trend is not statistically significant. Both procedures are quite good and have similar results. Symptom improvement in most patients, and a radiologic tumor response after the procedure. We also get with most patients, and basically what that means is that there's tumor death and perhaps shrinkage. Complications for these procedures. Post-embolization syndrome is quite common. Most patients will get it. It usually is self-limited and lasts a few days to a week. Mortality, again, we say literature says less than 5%. It's much lower than that probably. And other complications, infection, hematoma, biliary injuries, also quite low. As I mentioned before, when the drug-eluting bead TACE seems to have a higher incidence of biliary injury and abscess, so we basically just avoid that at this hospital. Moving on to radioembolization. So it's a similar procedure. Again, instead of injecting bland microspheres or chemo-loaded microspheres, we inject radioactive microspheres. And these microspheres embed in the tumors, which are hypervascular. And so when you inject the radiation into the hepatic artery, the tumors are sucking up that arterial blood, and they'll suck up the radiation preferentially compared to normal liver. Once those radiation spheres are embedded in the tumor, they decay over time, and most of that radiation dose is delivered after about 2 to 3 weeks. And the isotope that we use for this is Y90, and it only travels about 11 millimeters in tissue, so it really stays in the liver and really in the tumor, and there's not much radiation outside of the body or to other organs. There are two types of radioembolic devices that we use, resin and glass, and they're characteristically a little different. And so depending on the patient and the tumor and what things look like, we'll choose one or the other. But what you'll see down here is that neither of them are approved for neuroendocrine tumor, which basically means that we have to do a little fighting with insurance companies often, but the vast majority of the time we're able to get the procedure approved. Indications are similar for the other embolization procedures: tumor growth, symptomatic, less than 50 to 75 replacement of tumor by liver. And contraindications: liver dysfunction. If you've had a Whipple or a biliary stent, you have a higher incidence of infection after the procedure. If we're concerned that radiation will go to other parts of the body, like the lungs or the bowel, there are times when we may choose not to do this procedure. And poor functional status and tumors in other places outside of the liver are also relative contraindications. So how does the procedure work? It's actually split up into 3 different procedures if you're treating the whole liver. We start with what we call the mapping procedure. And during the mapping procedure, we inject contrast into the liver. We map the arteries. We look for arteries that come off of the liver arteries and may go to bowel, because we don't want any radiation getting into those arteries and irradiating the bowel. So if we see those aberrant arteries, we'll block them. And what we also do during the mapping procedure is inject a small test dose of radiation into the liver, and then we do a scan after the procedure to detect where that radiation goes. We want to make sure that the radiation stays in the liver. If the radiation goes to the lung or to the bowel, we know we have a problem, and we calculate actually a shunt of the radiation particles. If there's too much going to the wrong place, we may elect to avoid the procedure because it's not safe. After we do the mapping procedure, we'll calculate a dose, and we'll order the dose. It takes about a week to order the dose from the manufacturer. So we'll schedule the first treatment for a week after the mapping, a week or 2 weeks. We'll do 1 lobe typically, and then we'll do the next lobe 4 to 6 weeks later. So this is some angiographic pictures of the mapping procedure. And here, again, we're looking for vessels that feed bowels. So This is the GDA, and a while back we used to block that vessel all the time, but we typically don't now. It's not really, we can usually avoid it. But here's a vessel that's coming off. This is the right hepatic artery and the left hepatic artery, and here's a vessel going to bowel that's coming off the right hepatic artery. So if we're doing a right lobe radioembolization, we really want to block that vessel to make sure that radiation doesn't go to bowel. And in this picture, we've blocked both of those vessels, and we've injected contrast, and you see no contrast going into those vessels anymore, like you do here. So we know we have adequate protection, and it's going to be safe to do the procedure. And this is what the shunt study looks like when we inject that test dose of radiation. We do a nuclear medicine scan to detect where the radiation has gone, and most of that radiation is in the liver here, but you can see that the lungs are a little bit black, and so there's a little bit of radiation that went through the liver and to the lungs, and we'll basically do a calculation and make sure that it's still safe to give the radioembolization dose. So outcomes for radioembolization are also good, 70 to 80% symptom improvement and greater than 80% radiologic response, or disease control, I should say. Complications, it's common to have abdominal pain, nausea, vomiting. Often patients will complain of fatigue. Those are all self-limited. GI ulceration, when you get some of those radioactive spheres into the bowel, that happens, they can cause ulcers basically. That happens probably less than 1% of the time, not common at all. And the dreaded liver failure is also quite uncommon, and that, you really have to choose your patients wisely and correctly. This procedure is really all about patients. So all these procedures are about patient selection. And sort of long-term, neuroendocrine tumor patients that we've been talking about all day tend to live a long time, especially relative to other cancer patients. So we're finding with Y90, we're looking into sort of the long-term complications of Y90, and there are a couple articles published in the last year, 2 years, that have shown that, we need to be concerned about long-term effects with Y90. It can cause some scarring of the liver and increase pressures in the portal vein that feeds the liver. So that's something that we're really taking into consideration. It's kind of unclear at this point to what degree Y90 really leads to those outcomes, because a lot of these patients have had a lot of other things that can affect the liver, like chemotherapy, or they've had disease progression and have a fair amount of tumor in the liver. But it's something that I think about a lot when I see a patient with NET and we're considering radioembolization. And in fact, what we try to do now is inject the radiation directly into the tumor, and instead of showering the whole lobe with radiation, we try to, like with the chemoembolization, to be as selective as we can. And so here's some pictures from the radioembolization procedure, before and after. These dark areas are liver mets, and a little over 2 years later, those metastases are much smaller. Another patient, these are actually large tumors. There's not much normal liver here on this cut through the liver. And 3 months later, this patient has really had a dramatic response. Future considerations for interventional radiology and treatment of liver mets for NET. There's some studies that are going on right now that are looking at directing PRRT, giving PRRT directly into the hepatic artery. Right now we're just injecting it into the vein and it's going all over the body. But we're looking at whether, for people who have predominantly liver metastases, whether directing that PRRT into the artery is going to be effective. So in conclusion, we have several options for treating NET liver mets: ablation, bland embolization, chemoembolization, radioembolization. They're all great options. Patient selection is important, and all have been shown to decrease symptoms and slow down the disease progression. Thank you very much.